Cervical arterial dissections. We often find them summarized with this acronym, cervical artery dissection. They are also often referred to as arterial dissection. Dissection and dissecation are used as synonyms, although dissection is a bit more common in clinical settings. But what are dissections? Mechanically, they represent a tear in the intimal layer of the blood vessel. We know that the vessel is made up of several layers. In this case, the innermost one suffers a tear. And as you can see here, blood infiltrates the vessel wall. This is called an intramural hematoma, also known as a false lumen. The lumen is the space inside which blood travels within the blood vessel. What is the risk of a dissection like this? Well, obviously stenosis, the occlusion of the vessel, but also embolism, because this infiltration of blood sometimes precedes the formation of clots that risk breaking off and traveling through the bloodstream. Let's look at the three phases of dissection: the detachment of the flap, the formation of the intramural hematoma, and finally the actual occlusion. Now, we need to consider that this process is not immediate. It could take hours, days, or even weeks, so the person might have an ongoing dissection without knowing it. Later in the video, we will look at some possible signs that can reveal the presence of an ongoing dissection. Let's take a moment to look at the vascular anatomy of the arteries in the neck. We have the common artery, which branches into two, the internal carotid artery and the external carotid artery. And then there is also the vertebral artery, which can also be the site of dissections. As you can see, it has a particular path and shares spaces very closely with the vertebrae. I'll give you a fact that will be useful later. The sympathetic system, the autonomic nervous system, travels toward the skull by using this carotid highway, wrapping around it a bit like ivy. Remember this fact because it will help us understand one of the characteristic signs of arterial dissection. Let's talk about the numbers for dissection. But is it really that common? So in absolute terms, if we consider the entire population, no. But if we look at a certain group, those under 50 years old, then we're talking about 25% of cerebral ischemia cases being caused specifically by dissections. And this is exactly my age group, 40 to 49, where it goes up to 45%. Clearly, as we get older, the causes of ischemia are mainly due to age-related arteriosclerosis, but in younger people, dissection is a predominant cause. Why do we often associate dissections with the cervical region? Because the cervical region has unique mobility. It's an area where the arteries have to withstand extreme rotations and dynamic forces. And then, as we saw earlier in vascular anatomy, there's also the close relationship with the bones, that is, the anchoring of the vertebral artery to the transverse foramina, as we mentioned before, which makes it sensitive to sudden accelerations. Let's talk about the causes of dissection. Why does one of our vessels have to tear at a certain point? Well, there is certainly a genetic and biological predisposition, an alteration in the cellular structure of our vessels, in collagen, in elastin, and there is also a certain familial tendency. This is why, for the clinician and the physiotherapist, it is very important to know if there have been any cases of arterial dissection in the family. Then there are inflammatory factors. Clearly, infections can alter the integrity of our vessels, making them more fragile and weaker. Other connective tissue disorders such as fibromuscular dysplasia, Marfan syndrome, and type 4 Ehlers-Danlos syndrome. And then, when we talk about cerebrovascular lesions, we can never leave out hypertension, which produces chronic mechanical stress on the walls of our vessels. Other causes include mechanical triggers, of course, such as major traumas like high-energy car accidents, severe whiplash injuries, and even direct trauma to the cervical area. And then there are many other biomechanical stresses, such as other violent impacts. Think about sudden twists that occur in contact sports. Now let's talk about the symptoms. This is the most difficult part because, unfortunately, we often don't realize we have an arterial dissection until it results in a full-blown stroke, with the consequences we know all too well. Paralysis on one side of the body, loss of speech, cognitive changes, and altered perception. However, there is what is called the prodromal phase, from the Greek pro, meaning before, and dromos, meaning course or run, something that comes before, symptoms that could be indicative of an ongoing dissection. Often, these patients with dissection actually turn to the physiotherapist because they have neck pain or head pain, an atypical pain, and it is often interpreted as pain of musculoskeletal origin, so these patients request treatment. Let us remember that there is a critical period, a window of time from when the flap of the intimal layer of the vessel wall begins to detach until the actual occlusion occurs. It is in this prodromal phase that a very important clinical opportunity arises, if possible, to prevent these dissections, to prevent a true stroke caused by dissections. Let's also move on to this other particular symptom, Horner syndrome, more accurately called Bernard-Horner syndrome, because the physician Claude Bernard noticed these signs, especially those related to the eye. This syndrome is made up of three signs: miosis, ptosis, and anhidrosis. Miosis is the constriction of the pupil, meaning the pupil is unable to perform its function of widening and narrowing according to light exposure. It is a reflex. Ptosis is the drooping of the eyelid. The patient is unable to fully lift it. This movement of the eyelid also depends in part on the sympathetic nervous system, just like the pupillary reflex. In the complete Bernard-Horner syndrome, there is also this third symptom, which is anhidrosis, meaning the absence of sweating. However, in our case of arterial dissection, anhidrosis, or the absence of sweating, will not be present. Now let's see why. Do you remember that we saw in vascular anatomy that the sympathetic system reaches the skull by climbing along these arterial conduits? Well, here's an interesting fact. The sympathetic fibers that control sweating travel along the external carotid artery and not the internal carotid artery. However, 99% of carotid dissections occur precisely in the internal carotid artery, and that's why the patient might present with miosis, the pupil problem, and eyelid ptosis, but not with anhidrosis. So, by passing your hand over the patient's forehead, you might notice that even though the first two signs are present, there is still complete sweating on both the right and left sides. This starts to become quite a particular clue. Here we are talking about red flags, that is, warning signs that should prompt the rehabilitation professional to pay extra attention when undertaking a rehabilitation program with a patient, especially one who is showing problems in the cervical region. Well, first of all, and I will never tire of repeating this, when the patient presents symptoms that are included in the acronym FAST, which in English means fast, but where F stands for face, when the patient starts to have a drooping face on one side, and here begins to have paresis on one side of the body. A, arms, meaning limbs. The patient has weakness, difficulty moving both the arms and the legs. S stands for speech, words. The patient has difficulty speaking, mumbles, says words that make no sense. T is not a symptom, it stands for time. You need to hurry and call 112. This is a patient who must go immediately to the emergency room, to the stroke unit, or to the emergency room when unfortunately the stroke unit is not available. Other red flags include a new pain. When the patient experiences a completely new pain, often described as one of the worst ever felt, a headache, neck pain, the eye symptoms we mentioned earlier, and also pulsatile tinnitus, a pulsing ringing in the ears, because the internal carotid artery passes just a few millimeters from the petrous bone and almost acts as an amplifier, as if we could hear the sound of blood flow, interrupted precisely by that flap of the vessel's intimal layer that is blocking the passage of blood. So all these signs should prompt the physiotherapist to refer the patient either to the hospital if we are faced with fast signs, or to a doctor if we suspect that a dissection is occurring. With that, I say goodbye and thank you.